I have some limitation in ultrasound. First, bowel gas, fat people, adipose, uncooperative patient, dressing bandage. Sometimes, if thin patient, may be difficult to have ultrasound examination. Preparation have to fasting for 8 hours. Okay, patient should be spine. We have some different position, right lateral or left lateral. Any organ in ultrasound should be examined on two views, longitudinal section and transverse section. Then I have to comment on echogenicity texture according to shape. If I found a lesion, I have to talk about size, shape. Something is important here, respiration. In abdominal ultrasound, I have to ask the patient to take a deep breath to make organs more prominent. Okay. Probes, I have probe for adult and also microconvex for pediatric. May I use the superficial probe spleen for spleen microabscesses? First, the most important thing in kidney is I have to differentiate between renal cortex and medullary pyramids. Here renal cortex, and this is the medullary pyramids. Okay. I will comment on site of both kidneys, size, echogenicity, and if there is back pressure or stones or masses or cysts. Okay. Here I have scanning the kidney. I have to scan it on longitudinal section. I will get this picture. This is the cortex and this is the medullary pyramids. Okay, and I have also the renal fat. This is I will change the probe like this transverse section. I will get this as a round image. Okay, and this is the renal sinus fat. This is ultrasound anatomy of the kidneys, also renal cortex, medullary pyramids, and the renal sinus fat. Okay. Also, this is cranial. This is longitudinal section, and here is the upper pool, and this is the lower pool. If I get any measure for the kidney, I have to measure it in 3 planes: longitudinal section from cranial to caudal, anteroposterior, and from right to left, transverse. Scanning of the left kidney, I have to say something important. Both kidneys are retrorenal, so the anterior approach is very difficult, or maybe difficult. So I have to go back, ask the patient to to lean on any side, or right lateral or left lateral, and also I have to examine the patient on longitudinal section and also transverse section. This is very important. If I get this picture, I have to go up and down until to reach the upper pool and the lower pool. If I did this, I will not miss any pathology of the kidney or any other organ. According to ultrasound anatomical, I have upper pool and mid pool and the lower pool. If I want to describe a lesion, I should say it is upper or mid or lower according to the site. If I couldn't find the kidney, may I have to in the pelvis, I may have ectopic kidney. I have a splenorenal interface, and I have the diaphragm above the spleen. If I found a fluid, sorry. If I found the fluid below the diaphragm, this is ascites, and if above the diaphragm, it is pleural effusion. This is the left kidney. Also, I have to measure it on longitudinal section and transverse section. I have to comment on the size. It may be small size or it may be large size. Size of the kidney from 8 to 12 centimeters. I have also to comment on the renal echogenicity. It should be lower than, darker than the liver. Okay, this is a normal kidney, and this is echogenic kidney. Echogenicity of the kidney depends on maybe grade 1, grade 2, or grade 3. According to if it is echogenic than the liver, it is grade 2. If it is equal to the liver, it's grade 1. If I couldn't discriminate, it should be grade 3, echogenic 3. If it become smaller inside, it is grade 4. As I said, respiratory movement is important to discriminate the upper wall of the kidney. I have to ask the patient to take a deep breath. Common pathology, the most common is renal stones, calculus, renal cysts, angiomyolipoma, renal cell carcinoma, transition cell carcinoma, hydronephrosis, medullary spongy kidney. First, I will talk about back pressure. It may be mild, moderate, and severe. The obstruction may be at the pelvic junction, it may be at the ureter stool, or it may be at the lower prostate or in something in the renal bladder. This is the back pressure. This is dilated calyces. Okay. This is the renal cortex. This is the dilated renal pelvis. There is the cause of the renal back pressure is the stool, the renal calculus. Okay. If I have a baby or something pediatric, I have to I have to look for the renal sinus. If it is more than 10 millimeter, I will suspect there is pathological, there is hydronephrosis. This is a picture of renal stone and it called acoustic shadowing. Renal cysts, and this is a renal mass. The most important in the kidney, I have to exclude there is a renal mass or not. It is the most dangerous thing. If I saw a mass, I will first check for renal cell carcinoma. It is the most important point in this renal ultrasound. If I miss a stone or cyst or any other thing, it is not important. Okay. Cyst, it may be simple, thin wall, clear, no calcification, no septation, like this. It may be have thin septations or multiple septation. We have called the Bosniak classification. If it's clear, it is thin. If it has thin septi or microcalcification, it will be zero malignant. If it is more than 3 septi, it is I have to follow up. If the septi is second more than 3 millimeter, I have to suspicious for malignancy. If I said any sick septation or nodules, it is probably malignant. This is I said it may be renal cell carcinoma. This is a case of adult polycystic kidney. This is a normal kidney, and it is completely replaced by multiple small cysts. I have here a hypoechoic heterogeneous mid-polar lesion. It is probably malignant. I have to ask the patient to go to do for CT with contrast. Most echogenic lesion in ultrasound, it is probably benign. In the liver, on the spleen, or in the kidney, it is probably benign. I should also have to do for next step to exclude. I have here a lower polar soft tissue lesion. It's probably neoplastic. If I want to comment on the suprarenal adrenal glands, it is in the upper wall of the kidney. If I do renal Doppler, I can check for renal Doppler. When I do renal Doppler on stone, I have called something twinkle artifact. I don't have time. This is echogenic lesion angiomyolipoma. This is hydronephrosis. This is adult polycystic kidney. Sorry. I have to check. In conclusion, I have to check the kidney size. If both kidneys, if one of them is lesser than more than 10 centimeter, I have to ask for a isotope scan to exclude any other pathology of the smallest one. I have to check for the cortical thickness. It should be more than 10 millimeter. The differentiation between the cortex and medulla. I have to comment on this. Pyramids slightly hypoechoic. No hydronephrosis. No renal scarring. Spleen, this belongs to you. Spleen also covered by the colon, splenic flexure. So I have to go back to examine the spleen. I have to comment on the size, homogeneous, if there is focal lesion or not. Okay. Technique: spleen lies posterior to the splenic flexure, so I have to patient ask the patient to supine or on the right lateral position. Here is the right lateral. I have to look for the spleen. I have a video. I have to measure the spleen from the upper ball and the lower ball. Okay. This is the frame and this is the pleural effusion. I'm looking for. If I couldn't see the spleen, I have to ask the patient to write on the right lateral position and take a deep breath to get a better image for the spleen. Here is, I have to get the upper ball and the lower ball. I have to tilt the probe to get the image, to get the maximum bipolar dimension. Okay. Size according to the age. If anyone, you can look on the Google and search for spleen span. I have another formula. If you can add 6 centimeter on the third of the age of the baby, 6 centimeter, and for the liver it should be 9 centimeter nearly. Okay. I have to comment on echogenicity. This is splenomegaly, but it is homogeneous echogenic. This is also splenomegaly, but it has non-heterogeneous, multiple small hypoechoic focal lesions. This is the splenic hilum. I have to see it and exclude any other pathology on the splenic hilum. I have to put color Doppler to make it normal. Confirm it's normal. Okay. Sometimes spleen will be larger. I may have used some ultrasound machines have extended field of view to get the largest image. This is splenomegaly interface. This is the stomach. Sometimes we think it is a pathology or lesion in the spleen. This is the stomach and contain fluids. This is also the spleen, and above the spleen, this is the frame, and also we have pleural effusion. Most common pathology is splenomegaly, infectious, hemangioma, cysts, lymphoma, varices. Splenomegaly. Okay, I have also I can see collaterals, splenic varices. Splenomegaly, homogeneous splenomegaly. Okay. Splenomegaly, it is non-specific. It may be linked to infection, portal hypertension, hematological disorder, neoplastic condition. Okay. This is splenic varices. Okay. I have some. I can see spinule. Spinule, it is normal variant. It is homogeneous like the spleen. I can. Okay. It may be suspicious for lymph node, but if you can look, it is homogeneous. The same occlusion of the spleen. May be prominent after splenectomy. In hepatomegaly, the left lobe may extend across the abdomen. This is but false. I can suspect there is a lesion above the spleen, but it is hepatic. It is left lobe of the liver, and also I have splenule, splenic varices. Okay. This is the splenule. It is not a lymph nodes. Malignant specific lesion in the spleen, most common lymphoma. It may be single, maybe diffuse hepatic, diffuse splenomegaly. It may be focal, single or multiple, varying size. I have here a small hypofocal lesion. Mostly, as I said in the renal, if I say the mass, it may be renal cell carcinoma. Also in the spleen, if I say hypoechoic lesion, it is probably malignant. I have to exclude. This is splenomegaly with multiple hypoechoic nodes. It may be less common in the spleen. It may be also hypoechoic lesions. Benign condition cysts. Like any other cyst on the liver, spleen, kidneys. Sorry. I may say I may saw an cystic lesion with terrible content, likely abscess. Multiple biogenic abscesses, or maybe see in typhoid fever, malaria, sickle cell anemia. As also I said, in echogenic lesion, it is probably benign. Splenic hemangioma, liver hemangioma, angiomolyboma in the kidney. This is also hemangioma. I have to look for a splenic infarct in sickle cell anemia. It will be hypoechoic. When I bought color Doppler, I will. There is no color Doppler. It is mostly splenic infarcts. Also, I have to exclude splenic vein thrombosis. May I see some calcification? It is probably granulomatous infection, all the granulomatous infection. When I see a complex cystic lesion on the spleen, thick wall, it is, may I say hydrate cyst, or I have to exclude, I have to ask for a MRI with contrast. Splenic cysts. This is also biliary effusion. Spleen, ultrasound appearance of the most splenic lesion are non-specific. I have to consider history, clinical correlation. May I use fine needle aspiration? Pancreas. Head pancreatic echogenicity, it may be hypoechoic or hyperechoic. It is not significant echogenicity. I have to comment on head, body, tail. I have to ask the patient to drink more water, and I have to push the stomach out and make some compression to get a better image for the pancreas. This is a pancreatic anatomy. Head, body, and tail. Head not more than 3 centimeter. Body not more than 2 centimeter. Tail not more than 2.5 centimeters. Some pathology on the pancreas. It may be chronic pancreatitis. If I show multiple small hyper echogenic foci calcification, it is probably chronic pancreatitis. If it's enlarged, head enlarged and surrounded by echogenic fat, it is probably acute pancreatitis. After pancreatitis, I found pancreatic pseudocyst. Thank you for your attention. Okay.